I will be talking about Cholinoreceptor activating and Cholinesterase inhibiting drugs.
Cholinoreceptor activating and cholinesterase inhibiting drugs. So, acetylcholine receptor stimulants and cholinesterase inhibitors make up a large group of drugs that mimic acetylcholine. So, cholinoreceptor stimulants are classified pharmacologically by their spectrum of action depending on the type of receptor that is activated. So, Mimetics are also classified by their mechanism of action because some bind directly to cholinereceptors, whereas others act indirectly by inhibiting the hydrolysis of endogenous acetylcholine. So the major groups of cholinereceptor activating drugs, receptors, and targets in tissues are in the picture shown. So the basic pharmacology of the direct-acting cholinereceptor stimulants. So the direct-acting cholinomimetic drugs can be divided on the basis of chemical structure into esters of choline and alkaloids. Many of these drugs have effect on both receptors. Acetylcholine is typical. A few of them are highly selective for the muscarinic or for the nicotinic receptor. However, none of the clinically useful drugs is selective for receptor subtypes in either class. So the chemistry and pharmacokinetics. So first, we have to discuss about the structure. There are 4 important choline esters that have been studied extensively that are shown in this figure right here. So their permanently charged quaternary ammonium group renders them relatively insoluble to lipids. Next is the absorption, distribution, and metabolism. So choline esters are poorly absorbed and poorly distributed into the central nervous system because they are hydrophilic. Although all are hydrolyzed in the gastrointestinal tract and less active by the oral route, they differ markedly in their susceptibility to hydrolysis by cholinesterase. Acetylcholine is very rapidly hydrolyzed. Large amounts must be infused intravenously to achieve concentration sufficient to produce the detectable effects. So the pharmacodynamics. So the mechanism of action, first, acetylcholine released from parasympathetic nerves activates muscarinic receptors on effector cells to alter organ function directly. The second, acetylcholine released from the parasympathetic nerves interacts with muscarinic receptors on nerve terminals to inhibit the release of their neurotransmitter. By this mechanism, acetylcholine release and circulating muscarinic agonists indirectly alter organ function by modulating the effects of the parasympathetic and sympathetic nervous system and perhaps non-adrenergic, non-cholinergic systems. So the organ system effects. Most of the organ system effects of muscarinic cholinereceptor stimulants are readily predicted from knowledge of the effects of the parasympathetic nerve stimulation and the distribution of muscarinic receptors. So the effect of nicotinic agonists are similarly predictable from knowledge of the physiology of the autonomic ganglia and skeletal muscle, motor, and plate. So the effects of direct-acting cholinereceptor stimulants. Here, it is stated in this table, right here. So, next is the basic pharmacology of the indirect-acting cholinomimetics. So the actions of acetylcholine released from autonomic and somatic motor nerves are terminated by enzymatic hydrolysis of the molecule. So hydrolysis is accomplished by the action of acetylcholinesterase, which is present in high concentrations in cholinergic synapses. The indirect-acting cholinomimetics have their primary effect at the active site of this enzyme, although some also have direct actions at nicotinic actinic receptors. The chief differences between members of the group are chemical and pharmacokinetic. Their pharmacodynamic properties are almost identical. So the chemistry and pharmacokinetics, the structure. So there are three chemical groups in the cholinesterase inhibitors. First is the simple alcohols bearing a quaternary ammonium group. Second, the carbamic acid esters of alcohols having quaternary or tertiary ammonium groups. The third, organic derivatives of phosphoric acid. So this one, as you can see, are examples of the two chemical groups of cholinesterase inhibitors. So the structures of some organophosphate cholinesterase inhibitors, this one. So the dashed line indicates the bond that is hydrolyzed in binding to the enzyme. So absorption, distribution, and metabolism. Absorption of the quaternary carbamates from the conjunctiva, skin, gut, and lungs is predictably poor, since their permanent charge renders them relatively insoluble to lipids. Thus, much larger doses are required for oral administration than for parenteral injection. So, therapeutic uses and durations of action of cholinesterase inhibitors there. So, the pharmacodynamics. First is the mechanism of action. Acetylcholinesterase is the primary target of these drugs, but butyryl cholinesterase is also inhibited. Acetylcholinesterase is an extremely active enzyme. In the initial catalytic step, acetylcholine binds to the enzyme active site and is hydrolyzed, yielding free choline and acetylated enzyme. In second step, the covalent acetyl enzyme bond is split with the addition of water, or the process of hydration. So the entire process occurs in approximately 150 microseconds. So organ system effects. So the most prominent pharmacologic effect of cholinesterase inhibitors are on the cardiovascular and gastrointestinal systems, the eye, and the skeletal muscle neuromuscular junction. Because the primary action is to amplify the actions of endogenous acetylcholine, the effects are similar but not always identical to the effects of the direct-acting cholinomimetic agonist. So, in the central nervous system, in low concentrations, the lipid-soluble cholinesterase inhibitors cause diffuse activation on the electroencephalogram and a subjective alerting response. In higher concentrations, they cause generalized convulsions, which may be followed by coma and respiratory arrest. So in the eye, respiratory tract, gastrointestinal tract, and urinary tract, the effects of these inhibitors are well innervated by the parasympathetic nervous system, so they are qualitatively quite similar to the effects of direct-acting cholinomimetics. So in the cardiovascular system, they can increase activity in both sympathetic and parasympathetic ganglia supplying the heart and at the acetylcholine receptors on neuroeffector cells that receive cholinergic innervation. So in neuromuscular junction, the cholinesterase inhibitors have important therapeutic and toxic effects at the skeletal muscle neuromuscular junction. So the clinical pharmacology of cholinomimetics. So the major therapeutic use of cholinomimetics are to treat diseases of the eye. For example, are glaucoma and accommodative estropia. The GIT and urinary tracts, like the post-operative atony and neurogenic bladder, and the neuromuscular junction, myasthenia gravis, quarry-induced neuromuscular paralysis, and to treat patients with Alzheimer's. So cholinesterase inhibitors are occasionally used in treatment of atropine overdosage and very rarely the therapy of certain atrial arrhythmias. So for the clinical use for the eye,
They reduce intraocular pressure by causing contraction of the ciliary body as to facilitate outflow of the aqueous humor, and perhaps also by diminishing the rate of secretion. In GIT and urinary tracts, in clinical disorders that involve depression of smooth muscle activity without obstruction, cholinomimetic drugs with direct or indirect muscarinic effects may be helpful. So in neuromuscular junction, clinical situations in which severe myasthenia must be distinguished from excessive drug therapy usually occur in very ill myasthenic patients and must be managed in hospital with adequate emergency support systems. So in the heart, the short-acting cholinesterase inhibitor endrophonium was used to treat supraventricular tachyarrhythmias. So in anti-muscarinic drug intoxication, so is potentially lethal in children and may cause prolonged severe behavioral disturbances and arrhythmias in adults. So in the CNS, Tacrin is a drug with anti-cholinesterase and other cholinomimetic actions that has been used for the treatment of mild to moderate Alzheimer's disease. So for the toxicity, so since every drug, as discussed before, has a toxicity, so in the direct-acting muscarinic stimulants, so drugs such as pilocarpine and cholinesterase cause predictable signs in muscarinic excess when given in overdosage. These effects include nausea, vomiting, diarrhea, urinary urgency, salivation, sweating, cutaneous vasodilation, and bronchial constriction. So in the direct-acting nicotinic stimulants, the acute toxicity of the alkaloid is well defined but much less important than the chronic effects associated with smoking. In addition to tobacco products, nicotine is also used in insecticides. So in cholinesterase inhibitors, the acute toxic effects are like those of the direct-acting agents, which are direct extensions of their pharmacologic actions. So, in other words, it is not toxic unless it is given at the proper dose. So that will be all. Thank you.